So with that, we'll move into our final section, which is imaging in PAH and what's new in imaging in PAH. What are the strengths and weaknesses of imaging, various imaging modalities in the context of PAH? And I'll start with you, Dunbar. Just in the pediatric population, are there go-to imaging modalities that you use and others that you see on the horizon that may be promising?
Sure. So, I mean, we use standard echocardiography several times a year to monitor our patients. And as I mentioned before, we're able to do three-dimensional echo measures of RV function and strain. So we have been using that. One of our cardiologists, Dr. Joan, has been particularly interested. And then Dr. Burkett has looked at eccentricity index. Again, it's just something that is more objective. Then we use our standard other echo measures. So we do have a protocol for that, which I do think helps. We use MRI usually once a year, and the advantage here is we can compare this with our 3D echo measures, but we get a cardiac output measure that I think is fairly accurate. And then some groups are starting to look at septal curvature. Now, these SPECT or other modalities, particularly CT, we have not embraced. And a lot of this is related to radiation in small children. But MRI is being used more and more as we get so-called free breathing sequences, which allow us to not sedate younger children.
And Dr. Humbert, how can imaging aid in the assessment of PAH, particularly in diagnostic algorithms, and what's new since the 2015 guidelines?
Yeah, no, it's imaging is so important. First, in the diagnostic approach, where in adults we always want to identify possible CTEPH, even though we discuss mostly PAH today. But CTEPH is always in the back of our mind because, as Dunbar and yourself said, it is a treatable cause of pulmonary hypertension, and we screen for CTEPH thanks to VQ lung scan, and then we use imaging modalities like CTPA, computed tomography, pulmonary angiogram, and pulmonary angiography as a routine approach. Regarding MRI, it is very important to emphasize what Dunbar has said. It is a superb instrument. The difficulty is to have access to it. So worldwide, when you work in a major university campus, you have access to MRI, but in the community, it is certainly something we have to develop and promote and find solutions for our rare patients to have access to MRI. So right now, I would say that in our adult practice, we use a lot of echo. Echocardiography is certainly a very important screening tool, but also follow-up tool. And then we use more non-invasive parameters, which are more function class, walk distance, BNP, and the imaging is not that often repeated because we don't have access to MRI in many centers.
What's the chance that non-invasive imaging can actually pick up or identify the presence of PAH when it may not have necessarily been suspected by the usual routes of the patients presenting with symptoms? Oftentimes we see incidental findings, and one of them has been the pulmonary artery diameter. And I've gotten several referrals of adults, asymptomatic adults, who have had radiographic images reported as the presence of pulmonary hypertension based on imaging alone without really any workup. There's a study of a PA diameter and looking at CT-based PA diameter, usually CT-based, it can be echo-based. And an enlarged PA is grounds for concern. It makes one wonder if they have pulmonary hypertension. In one study, they looked at the PA diameter alone as a standalone criterion for PAH, and obviously without the rest of the workup, it's probably not very good. there have been some criteria that have been put forth, such as a PA diameter greater than 30 and a PA to aortic diameter ratio of greater than 0.9. We know generally the PA is supposed to be smaller than the aorta, regardless of what the absolute size is. Do you agree with these, Dunbar and Marc, that these are good screening tools, at least to increase or heighten the awareness that pH might need to be worked up?
If you want, I can start in the adult setting. The Fleischner Society produced these figures based on the systematic review of the literature, and clearly it can induce some suspicion, but there are so many circumstances where an enlarged PA is not associated with pulmonary hypertension. So when you have a patient with short of breath, with no cardiopulmonary known comorbidity and a large PA, it can be a reason for performing echo and subsequent investigation. But even in the absence of enlargement, you would do it if you have no explanation of the shortness of breath. So I think it's good to know, but in my center, in my teaching, I always tell, don't put too much emphasis on the size of the PA. When it is enlarged, okay, consider pulmonary hypertension as a possible cause, but if it is not enlarged, don't forget that it might be PH anyway.
I'll just add briefly that we get very few referrals from enlarged PA on CT scan. It's much more from routine routes and symptoms or evaluation of a patient with liver disease before transplant, those kind of things. But we see large PAs and we track that, but we don't. We get very few referrals specifically to say, does this patient have PH because the PA is enlarged?
Thank you, Dunbar. So we've talked about the VQ scan and the importance of not missing CTEPH because it's a potentially curable disease. And some folks have put forth the idea that their technology of dual energy CT can combine morphologic information with lung perfusion. And therefore, you get sort of the best of the VQ perfusion as well as the imaging from CT. Is that something that you use in France? Dr.
Well, thank you, Ron. It's very, very promising, but it's still investigational, I would say. Obviously, we use it. We have a research around that. But technically, it has to be said that it is not as simple as one would believe. And I think we need to define the exact gold standard for this dual energy assessment. And right now, in the guidelines, we still recommend VQ lung scan to exclude CTEPH. And dual energy will come soon, but it's not yet prime time.
Once you have a diagnosis, are you using other treatment modalities then to further characterize the CTEPH besides just a simple angiogram, a pulmonary angiogram?
Well, more and more, we are mastering the imaging capacities of the computed tomography pulmonary angiograms. Now we can make reconstructions. We can finally analyze the pulmonary arterial wall. We can find specific webs, bands, disruptions, which are really key when we discuss during our multidisciplinary meeting the best treatment strategy. Obviously, some patients are candidates for surgery, and this is the prime decision when in operable people, but many people are not operable and they may be very well approached by balloon pulmonary angioplasty, and these CTPA are very important. But then on top of that, of course, classic digital subtraction angiography remains very important for decision-making in many patients.
And Dr. Ivy, you mentioned that in pediatrics, the presence of CTEPH is not very common. Are you seeing any patients at all that have CTEPH and that have undergone, under 18 years old, undergone corrective surgery with pulmonary thromboendarterectomy?
Absolutely. Over 20 years, we've had about 10 patients who we found CTEPH and referred to UCSD for thromboendarterectomy. We have most of those patients luckily have been able to be treated, and some, we've had one patient with recurrent CTEPH in spite of appropriate therapy. But I think one challenge for me and a point for anyone that's listening is, again, that we need to look and think about it. In one of our top registry studies in the paper, I think less than 2% of patients who had idiopathic disease had a ventilation perfusion scan. And so I'm very worried that we're missing some of these patients that could be treated. And so I think it's important. I think myself and my colleagues continue to remind people to look for this, and particularly in those patients that we're calling idiopathic PAH.
Thank you. What imaging should be done after the surgery? If you've had a patient that's asymptomatic and the surgery was deemed successful and everyone's happy, is there any imaging that should be recommended? And more importantly, what about patients who have had a suboptimal response and they're still symptomatic?
Yeah, it's a great point. I mean, obviously, echocardiogram has to be repeated and repeated in the long run. A mistake is to miss these patients and to lose them from follow-up. So the key message is that surgery is fantastic, but after surgery, you need a follow-up. And this follow-up will be certainly very good with good messages, but some people, as you said, have suboptimal results of surgery. And in those circumstances, we repeat CTPA and angiogram, and it's quite common to have subsequent balloon pulmonary angioplasty after incomplete success of surgery. On top of that, sometimes patients benefit from pulmonary hypertension drugs because they have a component of small vessel vasculopathy, which is not treatable with surgery or BPA.
Let's look at what we can measure before and after treatment with imaging. In particular, one analysis looking at called the REPAIR study, looking at the effect of bosentan, endothelin blocker, on right ventricular function in PAH.
Yeah, we like to follow the patients up with good quality, robust imaging technology. And clearly, MRI has a lot of qualities which have to be acknowledged. And in the article published by Anton van Nodegraaff from the Netherlands on the REPAIR study, him and his group and his colleagues clearly show that with MRI imaging, you can show improvement in right heart chamber geometry and physiology of the pulmonary circulation. I would like to say that this is certainly very promising for the future of our field when MRI will be widely available. It is certainly a very important instrument to measure the size of the right ventricles, the size of the right atrium, and also the ejection fraction of the right ventricle. So we have fantastic imaging tools, and studies like REPAIR indicate that treatment intervention translate into modification of the parameters measured by MRI.
I think it's important here to understand, while MRI, as you said, is not ubiquitous and it can be particularly difficult in the community to get repeated MR evaluations of cardiac function, the right ventricle cannot be visualized adequately, at least not enough to do a study like this in a good percentage of patients, let's say up to 20+% of patients. So while we've seen studies looking at echocardiography, the individual patient who doesn't have good imaging by echo of the right ventricle is stuck either with some alternative modality to measure efficacy or finding an MRI, a center with expertise in MRI.
Yeah, it's entirely right. And in the future, the same way we discuss quality of life, the added value of quality of life on top of current risk stratification approach, I think MRI has a very promising future as an added imaging modality.
Thank you. Just to summarize this last section on imaging, the last decade has shown the importance of non-invasive imaging in the diagnostic approach of PH in the classification, prognosis, and treatment monitoring. While echo, CT, and VQ scans are an integral part of routine workup of patients with suspected PH, according to guidelines and across centers, there are some innovative new techniques that are on the horizon and applications in the field of PH, such as 3D echo, dual energy CT, 4D flow magnetic resonance imaging, T1 and extracellular volume fraction mapping. A lot of these we didn't have time to cover. Non-contrast enhanced MRI sequences for perfusion and ventilation, and molecular targeted PET scanning. All these things and more are emerging. Just to conclude for the 3 sessions that you have so graciously participated in, Dr. Ivy and Humbert, pediatric pulmonary vascular disease is a potentially devastating, life-threatening disorder. Therefore, early recognition leading to appropriate use of PAH-specific therapy is important. Patients should be empowered and engaged in all aspects of their PAH care with access to expert centers that provide a multidisciplinary approach, including shared decision-making and participation in education. And multiple imaging modalities continue to evolve and play vital roles to ensure accurate diagnosis and classification, to provide important prognostic information, and in the assessment of response to therapies, which ultimately dictates their outcomes. Thank you again for joining and participating in this session.
Thank you.
Thanks very much.